Dr. Baliga here. This podcast belongs to a set of 10 podcasts on the topic of geriatrics. It's from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It covers important topics including functional decline and frailty, cognitive impairment and dementia, evaluation of cognitively impaired elderly driver, depression in late life, hearing impairment, vision impairment, urinary incontinence, undernutrition, pharmacotherapeutic considerations in the elderly, including pharmacokinetics and pharmacodynamics, elder abuse and neglect, goals of care and advanced directives, and prognostication. After listening to these 10 podcasts, you should have a solid foundation in geriatrics and should help you provide better care to your senior citizen patients. This chapter is authored by Dr. Jeanette Ross, MD, who's professor at the University of Texas Health Science Center at San Antonio. She is the Associate Program Director for Geriatric Fellowship and Director of Didactic Activities for Palliative Care and Geriatric Fellows. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and the graduate medical educational levels. The senior author is Dr. Widera, MD, who is Professor of Clinical Medicine in the Division of Geriatrics at the University of California, San Francisco, UCSF. He is also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational interventions. Multiple choice question. A 72-year-old Caucasian female is brought to the doctor by her son because of problems due to poor memory. The son states that despite owning her own restaurant for decades, she has been forgetting ingredients in food while cooking new recipes, and she has been having difficulty handling the restaurant bills. Which of the following is the most likely diagnosis? A. Lewy body dementia. B. Vascular dementia. C. Alzheimer's dementia. And D. Normal pressure hydrocephalus. And the answer is C. Alzheimer's dementia. This patient has impairments in memory and executive function, suggestive of Alzheimer's dementia. This patient does not have the characteristic Parkinsonism, visual hallucinations, and other findings that would lead one to suspect Lewy body dementia. The steady, gradual progression of cognitive deficits, the paucity of vascular risk factors makes vascular dementia less likely. Normal pressure hydrocephalus classically presents with the clinical trial of cognitive impairment, gait disorder, and urinary incontinence. The four common types of dementia are Alzheimer's disease, vascular dementia, Lewy body dementia, and frontotemporal dementia. The important differential diagnosis is distinguishing between dementia, depression, and delirium. The cognitive evaluation of dementia includes mini-cog examination, which has been discussed in an earlier podcast, And the workup of dementia includes evaluation of treatable conditions such as depression, delirium, adverse drug effects, example anticholinergics, psychotropic or sedatives, metabolic derangements, hypothyroidism, alcohol abuse, infections, and vitamin deficiencies. A basic laboratory workup includes comprehensive metabolic panel, complete blood count, vitamin B12 and folate levels, TSH, syphilis, and HIV testing. Clinicians should consider neurological imaging studies in cases of onset prior to the age of 65, when there is sudden or rapid progression of symptoms, when there is evidence of focal and/or asymmetric neurological deficits, suspicion of normal pressure hydrocephalus, or recent head trauma history. An important aspect of aging is driving. There's a really interesting article by Dr. Louise Aronson titled "Don't Ruin My Life, Aging and Driving in the 21st Century" in the New England Journal of Medicine, February 21st, 2019. And her approach to the older driver includes that the key facts are that the older adults are driving more and further than in the past. Old age is not itself a high-risk condition for unsafe driving. Driving is a socio-medical issue akin to sex and substance use. Most older drivers are safe drivers with few risky driving behaviors. In accidents, older adults are at higher risk for injury and death. Driving retirement will be necessary for most of us as we age. As with younger drivers, some older drivers will be able to resume driving after treatment for relevant medical conditions. Key clinical responsibilities: maximizing health and function for safe driving, counseling patients about driving retirement, identifying high-risk drivers, reporting unsafe drivers. Laws vary by state, required in California, Delaware, New Jersey, Nevada, Oregon, and Philadelphia and Pennsylvania. Keeping up with evolving driving strategies and transport options. Key strategies include history taking, asking about driving as a part of routine health maintenance beginning at the age of 60 years. Asking about self-regulating behaviors, other changes in driving, accidents and near misses. Asking about driving specifics such as difficulty with turns, turn signals, parking, staying in lane, reversing, following traffic signs and maintaining usual speeds. Asking about transportation and other mobility needs and alternatives. Asking regarding neither self-report nor report from the family. Physical examination includes looking for potentially correctable conditions such as cataracts, glaucoma, medication side effects, hearing loss, significant joint or limb pain, many cardiac conditions, and sleep apnea. Progressive and generally non-correctable conditions such as most dementias, Parkinson's disease, macular degeneration, visual field defects, significant neuropathy, advanced arthritis, contractures, and paralysis. Other considerations include significant functional or psychiatric impairment, seizures, syncope, frequent falls or dizziness, and hypoglycemia. Testing, with the exception of road driving tests, no test reliably predicts driving fitness. Interventions. Dr. Louise Aronson recommends refer for rehab if there are functional deficits. Refer to a driving rehab specialist for adaptive equipment if there are motor or somatosensory deficits. If financially feasible, suggest modification of the car or a new car with needed safety measures. provide education or resources about safe driving, self-assessment, and community alternatives to driving. She recommends making your medical opinion clear regarding fitness to drive or not fit to drive, fitness with restrictions, or possibly fitness after recovery, rehab, and re-evaluation. She encourages you to advocate for optimized road signs, including contrast and size, safer roads and vehicles. Counseling. She recommends that you start early, before the topic is threatening to the patient, elicit the patient's concerns, goals, fears, needs, support, people, and plan. Make sure that the shared goal is safe driving for as long as possible. Normalize driving retirement. Empower patients to responsibly take control of planning for and executing their transition to passenger when the time comes. Consider an advanced driving directive and provide support and close follow-up after driving retirement. More in this outstanding article by Dr. Louise Aronson titled Don't Ruin My Life, Aging and Driving in the 21st Century, published in the New England Journal of Medicine, February 21st, 2019. This podcast is derived from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Jeanette Ross, MD, professor at the University of Texas Health Science Center at San Antonio. She is also the Associate Program Director for Geriatric Fellowship. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and graduate medical education levels. Her main interests include advanced communication skills, goals of care, pain management, and management of falls in the elderly. Her clinical activities are based in the South Texas VA healthcare system, where she is a staff physician within the Geriatrics department and extended care services, and she is affiliated with the Geriatric Research, Education and Clinical Center. She works in the Geriatrics and Palliative Care Consultation Service and the Geriatrics Clinic. Dr. Eric Widera, MD, is Professor of Clinical Medicine in the Division of Geriatrics at UCSF, that is University of California, San Francisco. He is also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational innovations. Dr. Widera accomplishes this through various leadership roles, including Director of the Hospice and Palliative Care Service at San Francisco VA Medical Center, and he is the Program Director for the Geriatric Fellowship at UCSF. He has been the recipient of numerous grants and awards, including a Geriatric Academic Center Award at the Hastings Center Kenneth Dixon Physician Award and the Hartford Foundation as a Center of Excellence Faculty Scholar Award.